FITECU. Y continuamos porque estamos ávidos de conocimiento y en estos 3 días deseamos llevarnos a casa un gran aprendizaje. Un aprendizaje que también nos ofrecerá el siguiente ponente. Ha sido pionero en la integración de tecnologías digitales en la educación y la atención sanitaria. Ha publicado más de 350 artículos relacionados con el desarrollo de dispositivos médicos y la innovación en la atención, siempre respaldada, eso sí, por las tecnologías digitales. Es una figura influyente, como les digo, en la educación quirúrgica, impulsando además la adopción de tecnologías emergentes para mejorar la formación de los profesionales en el ámbito de la salud y en la calidad de atención médica. Y además tiene muy claros los grandes retos de la tecnología en la prevención, diagnóstico e intervención del sector socio-sanitario. Es todo un honor tener en esta segunda edición de FITECU al cirujano experto en educación quirúrgica, investigador y profesor principal de la Universidad de Radboud de Nijmegen, en Países Bajos, a Harry van Goor. Un fuerte aplauso para recibirle. Please, Mr. van Goor, it's your turn.
Muchas gracias. Buenas tardes. Seguiré en inglés, es muy difícil español, so I continue in English, and I hope you can follow for the ones that are better in Spanish to follow my talk. I was assigned what we call an inspirational keynote, so I will exaggerate a little bit. Push you a little bit, your fantasy about healthcare in and out of hospital. And these are my disclaimers. So I do some advisory work for startups, both in the Netherlands and outside the Netherlands. My career in technology, particularly digital technology, digital innovation, started when I wore the Google Glass in 2013 during an operation. And that fascinated me very much about the potential of digital technology in healthcare, but also in the digital transformation or the transformation of healthcare. So how can we build a more sustainable healthcare now, but also in the future? So I became, from a surgeon, a more data-driven clinician. I expanded more my work into a digital transformer, and sometimes it's my fantasy that goes on and bring me into virtual world and being more a virtualist. My motto is, you don't have to see the whole stair before taking the first step. So I'm a little bit a guy who is more of learning by doing than talking with a lot of people, and then after a lot of talks and a lot of time, do the first step, and then you notice that it's the wrong step. So do the first step, try and error, and then you will see you will come far enough. I'll bring you a pessimistic message, because when you hear around on congresses internationally, not only in my country, but I guess in other countries in Europe, also in the United States, they say healthcare is broken. And the reason why healthcare is broken because of 3 things. It's the accessibility of healthcare, not only going to the hospital, also going to the GP, getting help, instant help, just-in-time help for patients is very difficult. And then obviously it's all about money. A lot of the budget of nations are going to more and more to healthcare. And then the workforce. There's a lack of certified workforce. Either it's nurses, in some countries it's doctors, but it's also social workers, etc. So in the whole chain of healthcare and social care. The Netherlands is a very small country, densely populated, and what you can see here is that even in a small country, the accessibility with public transport, and you see it in the middle map, is not good with public transport. And if you notice that the people that need healthcare most which is more people that are at risk, have a low-ish socioeconomic status, have no car, need to go by public transport, this is worrying. And the funny thing is, in the Netherlands, at the right side, you see that you are even more quicker by bike to go to the hospital than by bus. The other thing is that somehow healthcare is gone into waiting care. And I would say it's a disease of a lot of nations. Waiting is the norm nowadays, particularly in healthcare. And we noticed and we experienced also from the coronavirus period, epidemic, that waiting for help means there's bad care. You deteriorate, you get anxious, you get more stressful. And what you see here is the amount of money I already said that is go into the budget of nations. And you see the Netherlands is on the top. 10% of our national budget is going into healthcare. So it means that there's not enough money for other parts we have to do, for infrastructure, for houses, building houses, and for military. There's something going wrong? Yeah. So 30% of all these expenditures for healthcare is going into hospitals. And the funny thing is in the Netherlands that 94% of patients are completely cared for by the primary care, by physicians, by general physicians, by physiotherapists, by social care, by a lot of people that are working near the homes in the community. And only 6% are referred to the hospitals. So the hospitals get 30% of the budget and only 6% is referred. But the bigger problem is that the hospitals are becoming so efficient and reduce in hospital stay that they bounce back the patients again to the primary care. And that means that with all the technology we install in hospitals, with all the difficult and more complex operations we do, interventions, chemotherapy, cancer treatments, patients are treated, but with all their problems, they go out of the hospital and back in the primary care system. Then the last thing is, like I said, the workforce. These are Dutch data, but probably it's also applicable to other countries in Europe, maybe also Spain, that there is an expectation that in the near future, 2040, less people are working. So the Netherlands is 1 out of 2 is working. That the ratio between people that work in the healthcare sector, which is a public sector, and in other sectors where they earn the money, will go from 1 on 7 to 1 on 4. And then the other thing is that people at the age of 45 or 50 to 64, who are the people that have to take care for the elderly people, they are going to reduce from 10 to 1 to 4 to 1. And funnily, 30% of informal caregivers at home are health caregivers, are informal caregivers, are caregivers also working in hospitals or outside the hospitals. So I can say that our system is crashing and we have to do something about this. We just 2 years ago finished a very new building, hospital building, with the incentive to, let's say, have more hospitality to patients and more accessibility to patients. And I show you a little video about how it looks like, because we are very proud of this building, and it also had a first award on the European Health Design competition. See here the entrance without the reception desk. are lounges where patients and visitors can sit before they are going to the place where they are being treated. These are small waiting rooms. So in between, if you look at the outpatient clinic, we use round tables, so there's more contact between the specialist and the patient during consultation, and not a screen in between. And then there's a lot of space for people meeting, which is very important. Having particularly single rooms, so there are no double or sub-level networks anymore with technology. And these are layers that are for workers, because we notice more and more that if we don't care for the workers in the hospital, also outside the hospital, we can stop, say, healthcare and put this, because when these workers have burned out or whatever, we lose them before we can't treat the patient. It's all open, all to meet, to network together, and to share experience. And there's a lot of nature in it, and the building is staying. So it's climate proof. You see all the solar panels on the roof. I said to you, we are very proud, and we try to do something different within this building with virtual care, with distant care. The first one is that we recognize that we didn't know enough the patient who came to the hospital. So we copied the system from the Dutch, the KLM, the Dutch the flight company, in terms of the integrated patient journey. So now the patient gives much more information about the status at home we can use in the hospital. And this is all by an iPad. And there is facial recognition on the entrance, which means that you felt very welcome, because it said, well, welcome, Mr. this and this. And then you have this connected to your wayfinding, where you can find your way in the hospital. Wayfinding in the hospital is when it's not okay, it's very stressful for patients. Anxiety. Am I in time to see the doctor or the nurse? And the other thing is that we had a built-in, it's called the garden room, built-in teleconsulting room, a space with 18 cubicles where you can do virtual consulting and video consulting with the patients at home. And as you can see here, there's a lot of attention, not to the patients, but there are not coming patients in this area, but to the workers, to feel them have a higher well-being and like this way of doing healthcare. You see an example in such a cubicle, and actually what I want to show with this is that there's no computer in the way. You just have very direct contact online with the patient and the family. We did some research with it, and the patient told us that there are shorter waiting times because they don't have to sit there physically in a building, less stress, better accessibility, because patients that have no transportation can stay at home and don't have to organize transportation, and also equality. So during the consultation, the video consultation, it was, funny enough, it was much more equal in terms of the conversation than it was in the office. A reduced travel time and cost, which is on the own pocket expenses of the patient, 200 euros. That's a lot of money. And then obviously a lower carbon emission of 20 kilograms. But we are not so sure about the improved well-being at work of the caregivers, and also not the improved operability, because it's a completely total different operability when you do this in a hospital with your standard operability with physical people around, etc. And then also when we ask our doctors and nurses, what do you think about this virtual care? They say, well, it's okay, but I choose to see the patient in person. I want to touch the patients. That's my job. And this is not what I have chosen for. I bring you a little bit further. And actually showing that in my mind, when we go on with hospital care at the moment, we will have a broken system. Because nowadays what you see, but particularly in the Netherlands, and probably also in other countries, the hospitals are more focused factories with siloed departments. And I'll give you an example. When there's a patient coming in with a gallbladder disease, with gallstones, and most of these patients are overweight, have a bad lifestyle, the only thing surgeons are doing is they take the gallbladder out and then send the patient at home. But we know that this patient has risk to return 5 years later with a cardiac arrest, a cardiac problem, or with diabetes, or with other problems. And we as surgeons, we take no notice. We don't say to the patients, well, you have to lose weight because you are a risk for other diseases and not only the gallbladder diseases. That's the siloed departments. And that's also the case with what's going on outside the hospital. And with the increase of technology, doing more technical, difficult things, doing more and more to save the patient's life, it means that patients, when they leave the hospital, it's very complicated. They have side effects of medication, they have side effects of the intervention, of the surgery. But we throw them over the walls of the hospital. And then they are back in the system, in their family life, in their community, and they cry for help. And the only thing from the hospital we see is through this hole, we did a good job. We fixed, we repaired your problem. And this might be a little bit cynical, but telling that these patients are coming back, and we repair, and they come back again, and they come back again, means that this is not sustainable. This is what they call in English bringing coals to Newcastle or bringing water to the sea. So it's my firm opinion that the hospital care should transform. And they should transform from sickness care to health care. Because nowadays it's sickness care. We repair. We are repair shops in the hospitals. And we are not taking responsibility for the whole patient journey, going from the home to the hospital and from the hospital to the home. And why is that? Because we know that 50% of all health outcomes has nothing to do with care, with sickness care. It has to do with other things that is around you, which is income, ethnicity, cultural aspects, spiritual aspects, education, gender. And that's not something that we take into account enough in hospitals. And this is typically the domain in the primary care area, but also the domain in the homes, in your home, in other homes, in nursing homes, etc. So we need to intertwine care much more with health, education, living, food, income, community, cultural things, spirituality. You have to take that into account. And to give you an example, there was an experiment in a small city in the Netherlands where they were in, let's say, a couple of streets, a lot of people had a lot of debt. And they were depressed, had a lot of mental health issues. And instead of treating the mental health issues, their debts were gone by the local authorities. So they had no debt anymore from a certain moment. And then they get a coach to be sure that they have no debts anymore, and the diseases went down. They were reduced in their mental illness. There was no stress anymore. This is an example of that you care, not in a way of do patient care, but that you care in a way that you take the patient as a whole, holistic, with the environment, and are concentrating, focusing not only on the sickness, but also focusing on what's going on underneath the sickness. So probably the future of hospitals is more the community-based, integrated virtual care and health center. And why I'm saying virtual care and health center? Because nowadays it's not possible anymore to do all these intensive care and caring for health only physically. You need technology, you need distant care to organize this. And to push you a little bit further, what we also have to take into account in our society is that, believe it or not, we need to educate and to empower citizens more at home and their families and their informal caregivers. It will be a do-it-yourself. And it's not doing yourself in a way that it's doing yourself, you're alone, but together with your neighbors, with your family, etc. But then the system should guarantee that you have a 24/7 virtual first support. So no waiting times. If you have a question, you need to have an answer immediately. Actually, this works in Sweden with a telephone number, where nurses are behind the telephone number, and there's an enormous drop in GP visits by patients to the GPs and to the hospitals. And it can also be a triage, because people that need a hospital can be immediately sent to the hospital. And then the third layer could be a virtual expert, which means that me being a surgeon, I can be virtually connected in the system, and suppose that the virtual first support has some answers that is on my profession, I can give a virtual expert. And then what we forgot, but what has been experimented on in the UK, is the outreach. And this is 200 years ago, that doctors were going to the home of the patients. Hospitals 200 years ago were places to die. They were hospices. So we are now able to do our outreach, but now virtually, and going to the patient instead of the normal idea that patients have to go to the doctor or to the physiotherapist. And then obviously there are certain problems that need an admission to a hospital.
That's great. The live XR was kind of
cool. I give you a futurist. Can you raise a little bit of voice?
I'm glad it was correct. Also, the drone delivery with my medications arrived just as I got home, but I can't remember which pills to take or when. Can you tell me?
Yes, of course. The discharge summary states that you should take the pain medicine about 20 minutes before you put on your headset for your virtual reality meditation therapy.
And my leg, it's a little swollen as well. Should I be concerned?
First, let's run a thermal scan.
You have my permission.
Thank you. Voice print activation enabled. According to the scan, the skin's surface temperature and tensile grade is not suggestive of any complication of a clot in your leg.
Okay, well that's super helpful, Sol. I feel much better.
Yes, I can see and hear that. Your anxiety measures dropped 7 points.
That's so cool how you can just see that. What else did you find?
You were a little behind on your knee flexion goals compared to other people your age and gender at this time in their recovery. You only achieved 100 degrees of knee flexion and are not putting enough weight on your operated leg.
Well, what do you think I should do about that?
I will send your results to Dr. Beanie's office, as you might benefit from in-person physical therapy. I can arrange an automated insurance approval for the treatment.
Okay, well that makes sense. You have my permission. In the meantime, what should I do for exercise?
Voice print activation enabled. I sent the referral request and it was approved. We can review the exercises you should be doing, and if you can put on your rehab sensor shoes, I can help verbally guide your exercises.
Well, I like the idea, Sol, but can we do it a little later?
Of course. I'll reach out at 7 a.m. tomorrow morning.
You're kidding me, right? I'm supposed to be resting, remember?
Okay, fine. How does 9 o'clock sound?
That's much better.
Great. I scanned your home and see that you have a connected coffee maker. I'll set coffee to brew at 8:45.
Well, thank you.
What you see here is the future. And what you see here is a combination with telemonitoring, Internet of Things, XR, virtual reality. You see a humanoid, a virtual agent with artificial intelligence. You say teleconsulting, and it's using sensors. And although this is the future is nearby, because there are, on part of these, things, there's already a lot of progress. But more importantly, what you see, and it's more for the critical audience you are, for me, I see empathy between people. I see humor, which is important in a conversation between people. I see relaxing. I see shared decision-making, comfort, speed, and intelligence. So it means that for me it shows that virtual conversation, instead of in-person conversation, can be very powerful if you do it in a good way. It will work for the majority of people we know. Obviously, it won't work for a minority, and then you should do, let's say, the standard physical encounters we have now. Is this nearby? You probably heard a lot of, let's say, panel discussions already, yesterday and today, showing nice examples. But let's face it, when we look the world around, or in a country, in other countries, it's still, when you look at the Gartner hype cycle, still most of the technologies are on the left side, which is still an innovation. It's still not standard treatment. And when you see on the right side, there are only a few that are standard treatments now in healthcare. But anyway, like I said, I'm going to show you a couple of first steps we took to come to this, let's say, future of healthcare. 3 things: telemonitoring, ambient intelligence, and virtual reality. And you will see during all these 3 categories the starting role of artificial intelligence. And what you also see, you will see examples for in the hospital, but you can easily apply it to outside the hospital. So this is an example of all our patients in the wards that are in the hospital have continuous monitoring of their vital signs. So 24/7, every minute, it's in the electronic record, we have the data. There's no nurses need to take blood pressure, the pulse, or your respiratory rate anymore. And this means that they can see trends, they can see difference easily, and this was particularly very powerful during the COVID period, when there was isolation of patients and they had to dress up to go into the patient room. We show a lot of, let's say, what we call hard outcomes. Shorter hospital stay, no unplanned ICUs, etc. But more importantly, it had a tremendous effect on the nurses. The nurses felt that their care was much safer. The nurses felt that they had a boost in their craftsmanship. Their job satisfaction increased. Their workload reduced. And also they thought, well, this is an aspect of future nursing. We should keep this. And this means that we are now doing similar things with home nursing. So patients are continuously monitored on the dashboard, and home nurses are also reporting now, by case, that it's much more satisfying. So actually it's the total opposite, where you might expect that caregivers are very reluctant to these types of technology. They embrace the technology and they think it does a lot in terms of their jobs. Also, what is a spin-off of this is what we call command centers, virtual wards. So hospital-at-home types of organizations. So it means that there are, let's say, on an airport, similar things as on an airport, where you arrange everything digitally and online from one command center. And I don't know if you're familiar with the first virtual care center in the US. It's in St. Louis, it's called Mercy Virtual Hospital. And there, it's a building, there are no patients coming in, it's completely for healthcare workers, and they give a lot of care to other hospitals. They do triage, but they also give care to patients at home. There are constantly more than 100 people there working online and do virtual consultations. So what about ambient intelligence? And I'm going to maybe address a little bit this topic because that could be a term that's not familiar to you. And ambient intelligence is, let's say, to put it in simple words, it's to analyze all the interaction between humans and humans, but also between a human and an environment. That's called ambient intelligence. And ambient intelligence is based on AI, artificial intelligence, algorithms. And there's a very nice paper was there out in 2020 in Nature, which is a very prestigious journal, and with the title Illuminating the Dark Spaces of Healthcare with Ambient Intelligence, meaning that we don't know a lot about what is going on in healthcare in and outside the hospital. And this is not only in the hospital, but this can also be at your home, this can also be at a nursing home or another institution. We started to look at ambient intelligence in the hospital, and we are now busy with expanding it to elderly people at home to install the whole ambient intelligence system. And you see on the right side from this article what the potential gain would be. And for me, the most potential gain is that you get context factors. And that can support elderly people to live longer in their own home, independently, to give an insight in the day of chronic illness people, but also to give insight in lifestyle. And to give you an example, there are examples of ambient intelligence showing that the person is developing Parkinson's disease or developing dementia in their homes. And this is with an ambient system. If you compare it, if you combine it with wearables of insidables or whatever you want to name it, then it's even more powerful. We started very easy with what we call our R4Heal program, and the undertitle is Make Healing Sensible Again, but you could also convert it to Make Health Sensible Again, because this can apply not only to healing, recovering from an intervention in a hospital, but also to health in general. And there are three categories we focused on, which is healing or health by immersion and distraction. And you see an example from a patient room. And this might sound silly, but patients are bored in a hospital. Patients are isolated in a hospital. Patients feel lonely in a hospital. Well, you know, this is also the case in home and in other institutions, long-term care institutions. What I particularly see you on this video screen on the right side, we did some experiments with patients that had a delirium. Most of these patients have dementia and come into the hospital and go into a delirium. And we bring them out of the delirium by showing them videos from their past. And this can be, now it's not individualized, but you can even individualize this. And this is very powerful, just by when you have an exaltated person with a delirium, you can bring it back into a relaxed person by showing these videos. You can also use VR in the hospital for distraction, but also distraction of pain, so it's really a therapeutic. You can kill the pain, you can kill anxiety, reduce stress by using VR in the hospital. I come back to that later. Then the second point is healing by control, health by control. What I learned from elderly people is that the biggest thing in a hospital or living at home is loss of their independency. Everybody wants to be independent. To put it in the other words, nobody wants to be dependent on others. And that's a very important thing in terms of quality of life. When you go to the hospital, it's like everybody takes decisions for you. People touch you without any permission. They do things, and you have no control in it. So we brought over control on the nurse call. The control of the ambient environment means that you can close curtains yourself with technology, etc. And then the other thing is healing or health by interaction. Like I said before, loneliness is one of the biggest issues in nowadays modern societies. And loneliness is a big issue when you are in a hospital or at home. And these are typical ways of interaction. Interacting with your family, quite easily. Interaction with the staff from a distance. Suppose your doctor is not present, you can easily talk to your doctor or the nurse from a distance. You can also put in an A voice assistant, mean that you ask a question and you get a good answer. And then obviously the contact with home is very important. And then where comes the ambient intelligence in? It's the normal sensor, but it's the AI platform that's behind it. And I show you a little bit of an example of how we use this in the hospital to prevent a fall. Because the modern technology nowadays is not fall prevention, it's early fall detection. It already happened, it's early fall detection. And what we are doing here is, with AI, we try to look at common patterns of movements that predict for falling. And that means that we have done this here, and I can show you, we also connected to what we call the smart building, which means that a patient comes out of bed and probably wants to get out of bed to go to the toilet, but it's a fragile patient, so it means that the light goes on, and because the light goes on, it's the floor lights, they see the distance from the bed to the floor. Because that's, in 40% of the reasons, the fall in the hospitals of elderly people. And then you get a voice, you get an activated signal to the nurse station where you can say, stay in bed, your nurse is coming. And then they are less disoriented anymore, because one of the problems of falling is that they are disoriented in the patient room. And you can do this, you can map all types of data in the room, in a patient room, also in your hospital, and it looks like this on a dashboard. And it's privacy-proof because you see only stick fingers, and it's encrypted technology. But you can also use it in your hospital, in your nursing home for the workflow. You can look at nurse-patient interaction. You can look at food intake. And you can look at the cleaning, how the cleanings be done. So there's a lot of things. You can also use the ambient intelligence not only for information for care, but also for information how to organize and your operability of your institution. And then the last part is the virtual reality. I learned after 6 or 7 years of virtual reality research and patient care that it's we don't know a lot yet of virtual reality, the power of virtual reality. It is literally a treatment you have on your head and it interferes with your brain. And there is already some evidence that the hormones, the proteins in your brain are changing because of your virtual reality classes and what you experience in the virtual world. So there's still a lot to know in terms of how we can use it for diagnostics, but also for treatment. We launched a program a couple of years ago for VR in the hospital, but also VR at home, patients at home, or citizens, but also VR in the offices. And with offices, I mean physiotherapy office, GP office, but also other offices outside the hospital. And you see here a couple of examples in the hospital. Young people, elderly people, disabled people, and also different parts of treatment. And patients tell us that it's not only for stress and anxiety, having the headset in the hospital, taking on the hospital, but it's also what they say, to be in another world than the hospital world. Because they tell us that the hospital world is very let's say, gives a lot of pressure on them. This also, not only as a therapeutic in pain or anxiety or stress or rehabilitation, but also to use this system to go away from the hospital, to experience, to be at least for a couple of minutes outside the misery you are in a hospital when you are very sick. You see here what we experience very much. This is a truck driver. He's from Poland, and he had an accident. And I show this because he speaks in English, but he's completely in the virtual world. He doesn't give any attention on what's going on, and he, let's say, talks about his experience, what he is seeing. And you see here another example of a small child who has the third time of plaster switch.
Gorilla's en die boven in de bocht nemen. De onder hangt op de kop.
He sees gorillas and elephants, and this young boy, before we had to give him a painkiller, and we had to use one nurse to keep him down, to keep him calm. And now with one virtual reality headset, you see he's not noticing anything what's going on in changing the plaster. And this is an example of a patient after COVID disease, has long COVID complaints, very nasty complaints, and exercising at the physiotherapy office. And actually this patient took the classes at home, exercised at home, and forgot the time. And we could see on his data that his oxygen saturation dropped. So he exercised too much, but he was so in the game and in the exercise that he lose his time sensing. And this is also a powerful effect of virtual reality. When you are in virtual reality, and we use it also for women who give birth and are in labor, it is a couple of hours, and when they take on the headset for treatment of their pain, and they take off the headset, they think that it's only half an hour is gone, and then there's 2 or 3 hours gone. So the time compression, we call it, can be also used and very effective in terms of treatment. So we connected this also all together outside the hospital in what we call a virtual connected care by a medical service center. And we use the medical service center, which is an independent center, because what I say before, that the people that work in the hospital have not, what I say, the good DNA to do virtual care. And the medical service center, who serves 20, 30, 40,000 people online, mostly elderly people, they know this job. They are very used to do online consultation and to interpret the data. So we started this collaboration with the medical service center and the company that provided us with the VR headsets and the content, and we designed together and with patients this process of help desk, telehealth dashboard. Also, you have to take care of your purchase distribution, so well, you have to have a company that brings the headsets to the patient, your hygiene, your cleaning of the headsets, etc. And then, obviously, you have to also have a leveled virtual care, which means that there can be constant contact in one administrative electronic dossier that also me as an expert in surgery, so to speak, but also physiotherapists can enter on the same dashboard and can help the patient. So this is how we organize this now for fit for surgery, so prehabilitation, people training 4 weeks before surgery. We also do it for rehabilitation, for patients after cardiac disease, at home, heart failure. We do it for a lot of things, patients with low back pain, and like I showed you, patients with post-COVID complaints. We did a business case. This is half of the cost when you would do this the same with in-person, the standard therapy. So it's also cheaper. I show you an example how this goes on, and this is from a patient with long COVID.
Since the outbreak of COVID-19, data indicates that 5 to 20% of all people infected with COVID-19 seem to experience lasting physical, mental, and cognitive complaints. These are referred to as long COVID. This adds new layers of complexity and cost to pre-existing healthcare challenges. A new model of care is needed to help these patients. This approach is multi-domain, home-facilitated virtual reality rehabilitation via virtual connected care solutions. The approach starts with an order from the patient's healthcare provider for a virtual reality toolkit. Based on a patient's needs, the toolkit is prepared in a local virtual connected care center. The toolkit is distributed by a sustainable transportation service and delivered directly at the patient's house.
It's the Netherlands.
The toolkit consists of a virtual reality headset, a smartwatch for measuring vital signs of patients during virtual reality use, and a tablet for telehealth consulting.
Hey, hoi.
Hi.
Hi.
The For a Healthy Me remote care telehealth platform moves the center of care beyond the walls of the treatment center. Using the virtual reality headset and the accompanying smartwatch, the patient also receives support on what game to play, at what levels, and how often. A set of games developed by SyncVR Medical is installed on the headset. Games include physical exercises, relaxation and breathing exercises, and games for cognitive training.
So you hear that it's a multi-component treatment, so it's not only physical, it's also mental training and also
The games are appealing for
cognitive
users.
training.
They are fun and motivating patients to rehabilitate. All games can be personalized to individual needs and abilities. The integrated solution equips the healthcare provider with clinical applications, video analytics, and data into the use of virtual reality and into the vital signs of the patient. This enables the caregiver to monitor and make intelligent decisions about the patient's care. This includes ensuring that the patient does not exercise too much. Via mail and video calls, the healthcare provider supports the patient at a distance using virtual reality for rehabilitation. Healthcare providers are empowered to administer fast, temporary, and tailor-made support at a distance.
You see here an example of
For example, the provider
reading
can alter a
exercise.
treatment plan
We
based on the
also
review
do
of
this
the
with
heart and respiratory
patients
rate
with
and other relevant
asthma
data.
and COPD, so chronic lung illness.
The patient provides feedback on the use of virtual reality via online measurement scales that are sent via the telehealth platform. These questionnaires enhance the capabilities for personalizing the virtual reality of the needs of the patient.
So within the system, you have a constant evaluation of the experience of people, not only by the subjective filling in surveys, but also with the data that come from the headset,
connected care
and also the data
to lower
come from the
costs,
wearables.
achieve efficiencies, deliver better outcomes, and increase patient satisfaction.
So this is an example of how we approach and take our responsibility as a hospital to service people outside the hospital and go in the direction of a self-management tool, but 24/7 supported also by data, by people online. A last word, because you saw a lot of AI on AI. Last year I was at a conference and people were saying, will it be ethical not to adopt AI. And this is sort of an out-of-the-box thinking. So instead of all the security things and mistrust in AI, doctors were saying probably in the future it will be ethical not to adopt AI. But to give you a warning, this has only to do with AI that supports HI, which is human intelligence. So it means it's not by replacing humans by AI, it's AI in a sense that it supports caregivers, supporting their decision making, and there the AI can make a lot of differences. So what we also did is with a lot of stakeholder interviews and analysis, they told us what is the barrier, patients, the barriers in AI. And one of them is the data. We always say rubbish in, rubbish out. If you have bad data, then you never get a good AI predictive or whatsoever. And then regulation. If it's not regulated, if there's not such a sort of regulation, and the FDA is much better in the US in doing this than in Europe, Europe is far behind this, then people don't trust the AI they use. Inclusivity. A lot of the AI is developed, is trained, so the data sets are trained on cases that are not inclusive. You're probably all familiar with that, and that's very important because if you look at AI, you need to know where the data are trained on, and is this on the population that you take responsibility of. And then, like I said, AI is all about trust. You have to trust the AI, so people that make the AI have the responsibility to explain how it works. They have to explain how their AI works in terms of in the healthcare. So what they also came up, the interviews and the stakeholders was, we need education. You need to educate us in AI. We want to be present from the beginning with developing AI, so co-design. And then also they say, well, you need to certify your AI, because if you're not certifying your AI, we are not going to trust it. So with that, I end my talk, and thank you very much for your listening.
Thank you so much. The time. Grandes palabras y también muy sabias las que hemos escuchado en esta última ponencia de la mañana y también de la jornada. Tenemos tiempo ahora para tomar un poquito el aire y comentar todo lo aprendido durante la comida que ya nos espera. Y a las 3:30 les recuerdo que en la feria podemos disfrutar en el Shop Lab Point de varias empresas que van a seguir con esas demostraciones tecnológicas. Es el caso de la empresa Inrobix, que tendrá un coterapeuta robótico inteligente que acompaña y ayuda a mejorar el bienestar social, mental y físico de las personas. También estará presente la empresa Envita con historias para curar, historias para cuidar. El valor de la historia de la vida. Otra de las empresas presentes será el grupo Salto. Y por último tendremos a Intras con Ágil, el futuro del apoyo digital para tu proyecto de vida. Nosotros volvemos a este escenario central a las 5 de la tarde. Disfruten y no se pierdan esas demostraciones tecnológicas que sin duda también están hablando y dando muestra de que el futuro de los cuidados también está en nuestras manos. Muchas gracias.